actually show that the interventions are safer than the risk of obesity itself, and they are shown to be highly efficacious. There is a move towards early treatment with low BMI patients. We know that when patients start picking up weight, they continue to pick up weight. So we want to treat them earlier using holistic guides as opposed to traditional BMI-based guidelines. I think BMI is largely falling out of favor, and we've already alluded to the fact that we are looking more now at body composition, your fat percentage, and waist circumference, and a whole host of other, what I like to call holistic parameters. These are important concepts, and I want you to remember this throughout my presentation. In terms of bariatric interventions, there's a concept of restriction, there's a concept of malabsorption, combining the two, restriction and malabsorption, and now we're moving to what is called pure metabolic procedures. There are two key components in terms of bariatric interventions, and that is gastric reduction, which means you make the stomach smaller, or your capacity or your volume smaller of your intake, plus a small intestinal bypass. So you do only a gastric reduction, or you can combine a gastric reduction with an intestinal bypass. And the effect is really caloric reduction, reduced caloric absorption for the calories that have been ingested, microbiome change, and a whole host of metabolic change. You actually see the metabolic change soon after surgery. Before they even start losing weight, we find that the glucose has now normalized. And what is the goal of bariatric interventions? We must be careful not to push patients from one element of malnutrition, which is obesity, to the other extreme, which is a very emaciated patient. We really want happy, healthy, lean patients with a good quality of life. And the ethos and the philosophy of the surgeon is absolutely vital. Bariatric medicine or bariatric practice has traditionally been very difficult to understand. And the reason for this is traditionally surgeons deal with pathology and anatomy. We have a cancer in the colon, we remove it, and we can see that under a microscope. With bariatric practices, we are operating on normal, healthy organs for metabolic benefit. And therefore, the results very much lie in the hands of a practitioner who has a good ethos and philosophy of bariatric practice. These are exceptional procedures, and it's important to remember that no procedure fails the patient. They are well-studied procedures, and rather it is a patient who fails the procedure. At Ahmed Al Qadi Hospital in Durban, we have a very simple 3-step program. We do an upper endoscopy to assess the upper GI tract. We do a set of bloods and ultrasound to evaluate for gallstones. If patients have gallstones, we do a concomitant or the same time cholecystectomy with the bariatric procedure. And in the post-op period, we monitor the patients for the development of gallstones. As soon as possible time that they do develop gallstones, we encourage a laparoscopic cholecystectomy. Medical assessment is done by an obesity general practitioner or a specialist physician. The dietitian's role is absolutely key. Rara sees our patients pre-op, peri-op, and even in the post-op period. And in our program, we don't insist on pre-op weight loss. We believe it's a treatment paradox. If you are able to lose the weight on your own, you really don't need our services. And we do not encourage prolonged liquid diets. Ultimately, the incidence of obesity is increasing. By 2030, 50% of the world's population will be obese, and we really want to make accessing services easier. We want to remove obstacles to patients receiving bariatric interventions. Psychological assessment, we don't insist on this as a routine, unless of course somebody has a pre-existing psychological or psychiatric issue. To get into the interventions, this is the intragastric balloon, which I introduced to South Africa in 2017. It takes only about 15 or 20 minutes to do. You're looking at about 15 to 20 kilogram weight loss in about 6 months, done as a day procedure via the mouth with some sedation. Very effective procedure. And some of the features that I like about the intragastric balloon is that it's repeatable, it's reversible, and it is completely anatomy preserving, which means when the balloon comes out, the anatomy of the stomach stays the same. We've had a lot of intragastric balloon patients who then come to us later on to follow on with bariatric surgery. Now, these are restrictions. You'll remember that I mentioned this early in my talk. Intragastric balloon, and then we have surgery, the adjustable gastric band, where a gastric band is put around the upper portion of the stomach, constricted to reduce your energy intake. The problem with this is that it's a foreign body. The proximal pouch undergoes dilatation, and then what happens is the capacity increases, patients pick up weight, and I can tell you, putting a foreign body around the stomach is problematic. Oftentimes this patient comes for surgery later on, the band has eroded into the stomach, it's difficult to separate the band from the stomach, etc. So this is a bariatric surgical procedure which we do not favor and has largely fallen out of favor in the international arena. The laparoscopic sleeve gastrectomy is the most common bariatric surgery done around the world, and the reason for this is because it is relatively technically easier to do. The excised portion of the stomach, as you can see, is removed, and it is in that area where the satiety hormone ghrelin is contained. This surgery has probably about a 40% failure rate, but actually it's a loaded statement to make. All bariatric surgeries have their advantages, and our indications for a laparoscopic sleeve gastrectomy is in adolescents, young females, and patients who have contraindications to bypass. It is a good procedure to have. If patients pick up weight in future, we can always convert the sleeve to a bypass and give the patients obesity protection throughout their entire life. Also, keeping with the theme of restriction, the Iranians introduced this because they couldn't get access to staplers, and what this literally means is that the greater curvature of the stomach is now invaginated with suture material to simulate a sleeve gastrectomy, and there is no use of staples in this operation, and the patients do as well as they do the sleeve gastrectomy operation. Then people have then gone on to say, okay, what if we don't suture it and we don't staple? Isn't there some big clamp we can put on the stomach? And yes, obviously with industry, there will be some commercial element. The body clip is one of them and the B clamp is the other. As I've said before, I do not favor the use of foreign material on the stomach, but these patients do as well as sleeve gastrectomy patients. New kid on the block, the endoscopic sleeve gastrectomy. So like the plication where we invaginate it from the outside, now with the endoscope we are able to do this from the inside. Patients do almost as well as a sleeve gastrectomy operation, but this is not just purely an outpatient procedure. These patients have a general anesthetic and it is very distal heavy, which means the bottom of the stomach is constricted, but the fundus, which has a large reservoir, is somewhat neglected, and patients can pick up weight as a result of a neglected fundus. The Roux-en-Y gastric bypass was traditionally regarded as a gold standard procedure. Not really sure why, but it's probably just been around for a long time. We have a small pouch at the top, and we have the intestine transected, and this is what was called a traditional laparoscopic gastric bypass. The problem with this is, although it's a bypass, the stomach is very small. Patients are unable to eat. The anastomosis between the stomach and the intestine is very tight, and when that pouch dilates, a lot of these patients pick up weight in the future, and there are no good revisional options for them. The mini gastric bypass, nothing really mini about it, but it's just another name given to it, where we have a longer stomach and we do not transect the small intestine. We make a loop anastomosis to the neostomach, and these patients do exceptionally well with one anastomosis as compared to two with the Roux-en-Y gastric bypass, and it is a reversible procedure. The biliopancreatic diversion and duodenal switch, also done in Roux-en-Y configuration. You can do a distal gastrectomy, or you can do a sleeve and then do an anastomosis. And the problem with this over the years is very good for weight loss, very good for comorbidity resolution, but technically difficult. There are technical risks involved in the procedure, and the problem is that the common channel is small and these patients are at higher risk of nutritional deficiencies. So over the years, we've had to adjust our surgeons in terms of the fact, how can we give you good weight loss? How can we give you good comorbidity resolution? How can we keep a happy, healthy patient who's able to eat, give you a reversible procedure, but not compromise results and not simultaneously risk the issue of having nutritional deficiencies? Also, this is a new term that's bandied around called sleeve plus procedures. Basically, it is a sleeve gastrectomy procedure combined with some sort of a bypass, and many of them are listed here, somewhat becoming disillusioned over the years with purely stomach procedures. So like the gastrectomy and the sleeve gastrectomy and the plication, where we're working only on the stomach and not on the small intestine. We find that when we add an intestinal bypass of some sort, the bariatric results are always better. SADI is very much like the duodenal switch operation, but it's SA single anastomosis. We're going towards reduced amount of anastomosis as opposed to transecting the intestine and fashioning things in Roux-en-Y format. The newer procedures coming around is what we call transit bipartition. So basically what we're saying is that instead of occluding the pylorus, we want to be able to get down to the intestine should there be a need for access to the biliary tree, and then we do an anastomosis to the stomach. The only problem with that is if you keep two avenues for food to go, what happens then? Does food go into the duodenum? Does food go into the anastomosis? And it causes a little bit of inconsistent results. The earlier studies are showing that obviously food will go through the path of least resistance, which is through the anastomosis. It goes through the intestine. Later on, there is what we call an ileal break, which means less food goes through the intestine, more food goes through the pylorus, and then through the rest of the intestine in that fashion. But this is still investigational at this point, but something to watch. If I had to recommend any two bariatric surgeries at the moment, the sleeve gastrectomy for moderate weight loss, for a young patient, for an adolescent, young female, and anything beyond that, we can do one anastomosis or mini gastric bypass, and we are able to tailor the biliopancreatic limb in terms of your weight loss requirements. So if you have a patient with a BMI of 35 or you have a patient with a BMI of 65, we're able to tailor the same operation so that we are able to meet your weight loss requirements. In conclusion, what I want to reiterate is that the bariatric procedures are the mainstay. These are the kings of weight loss therapy. We now have a fast-track system where patients are spending almost less than 24 hours in the hospital. They come in an hour or two before surgery. We want the reduced amount of time in theatre and in hospital. Sleeve gastrectomies we can now do as same-day procedures or day cases. No pun intended. One must not be greedy with weight loss. If you get too aggressive with your procedures, the patients will suffer in terms of nutritional deficiencies. But if your philosophy and ethos is correct, and you do a responsible procedure, and the patient is able to meet you halfway with the process, the patient do exceptionally well, and they actually saw in terms of their overall health. The future is going to be advances in technology, magnetic anastomosis, hybrid procedures. Hybrid procedures is where we combine endoscopic and surgical procedures. We really want to use less staples. That's what adds a lot of cost to these procedures. And there's a lot of focus on bypass lengths. Bypass lengths meaning when we do a bypass for patient, do we settle on an exact amount of bypass, or because remember the small intestine is different in every patient. The problem with fixed length bypasses is if you do a 2-meter bypass on X patient and you do a 2-meter bypass on Y patient, you are likely to get different results because the overall intestinal length is different, and we are moving towards more percentage calculation in terms of measuring the entire small bowel and maybe doing a 1/3 or a 2/3 bypass of that particular patient's intestinal length. GLP-1 drugs are the new kids on the block. We are not in competition, nor do we feel threatened by GLP-1 drugs. I am exceptionally for anything that will help the patient to lose weight, and we often combine our GLP-1 drugs with surgery, and we combine it with intervention to optimize. I think we must stop looking at bariatric practice in terms of rigid boxes. We don't want rigidity. We want patients to be able to benefit from multimodal therapy, and that means using endoscopy with surgery, with medication to optimize and give the patient the best chance of losing weight. That's exactly what we want. Remember, losing weight is exceptionally difficult, and we want successful, happy patients. And that's about it from me, and maybe at the end of the session we can take some questions. Thank you very much.